Okay, sorry guys. I think there was a person who interrupted the whole of the thing and was not able to continue. And I'm going to just do something for this. And so I don't know how he changed the things. Okay. Thanks, Venkat, for coming back. I think we are in again, and yes. So let me just okay. Now I'm going to just make sure that and try to be more, more vigilant because there was a person who became the host, and I was not able to share the video and share the picture. And if someone wants to do some research in the Zoom, please try to do it when there is something with your kids of with funny things. But when this something happening here like this session, I think there should not be anyone who's playing with this Zoom app. Okay, coming on to the slide. So this is what I was discussing about the biliary pain, a typical biliary pain. How will it be, and how how it is um, um, perceived by the patient. And coming on to the next slide, I think I discussed about this thing. So this is a picture where there is a uh, uh, just a okay, this is a picture. This is a slide where we can see the how the supersaturation of the things, how the supersaturation of the crystals are the things which causes the gallstones. For example, I said there is a chance of formation of the gallstone when there is a mucin, thickened mucin around which the crystallization happens, and there is a formation of gallstones. And if there is an increased proportion of cholesterol, or if there is an increased proportion of bile acids or bile pigments, there is a chances of formation of gallstones. And comes next is the okay. What are the types of common bile duct stones? I would like to pause here for a while, and there was a Facebook live which was going on, and that was interrupted because of this. And okay, let me just do it later on. Okay, so what are the types of common bile duct? So common bile duct stones can be can be of two types. Primary stones are usually the brown stones. What is primary stones? The primary stones are nothing but the stones which are formed in the common bile duct even after laparoscopic cholecystectomy. For example, there's no gallbladder which showers the stones into the common bile duct, and the secondary common bile duct stones are nothing but most of the time it's cholesterol stones, and it is from the it's from the gallbladder. So common bile duct stones can be primary or the secondary. Primary, it gets formed in the common bile duct probably because of biliary dyskinesia. That means that there is a decreased peristalsis in the there's a decreased peristalsis in the common bile duct which forms the common bile duct stones, or there can be spasm in the sphincter of Oddi which causes stasis of the common bile duct which causes the common bile duct stones, or sometimes it can be because of the choledochal cyst, or there is a stasis of the bile in the common bile duct. Secondary stones, as I said, it could be from the it could be from the uh, uh, gallbladder. So, what is meant by recurrent stones in common bile duct? Usually, after laparoscopic cholecystectomy, there is a chance of formation of there's a chance of formation of common bile duct stones uh, in common bile duct. So if it is in the if it is less if it is after 2 years of laparoscopic cholecystectomy, it is called as recurrent stones or recurrent common bile duct stones. So these are the few things which is very important to be uh, which are very important. So 8 to 16% of patients with symptomatic gallbladder stones will have simultaneous common bile duct stones, and that means gallbladder stones will be with the common bile duct stones in almost 8 to 16% of the patients, and there can be asymptomatic common bile duct stones. Usually, common bile duct stones presents as obstructive jaundice, not always. There can be sometimes a partial obstruction with mild elevation, or there can be complete obstruction with full-blown elevation of the bilirubin and the alkaline phosphatase and gamma glutamyl transferase. Other again, the same thing goes for pale stools and the dark urine. Sometimes the pale stool may not be there because of partial obstruction, and the dark urine may not be there when there is a decreased bilirubin in the u. Uh, uh, may not be there when the bilirubin level is not up to the mark, and especially as I said, you in the early phases of obstruction, or when there is an incomplete biliary obstruction, these classical signs may not be uh, elicited in a patient with common bile duct stones. So when we say about common bile duct stones, we have to mention about the Kuhn law. So there won't be any distension of the gallbladder, though there is a common bile duct stone, and there's some exception for this Kuhn law, and jaundice associated with malignant obstruction, which is usually is painless. However, when there is a jaundice, obstructive jaundice with a common bile duct stone, it is usually painful. So the next slide is and the symptoms. The classical symptom of any common bile duct stone is Charcot's triad or the Charcot's cholangitis triad. So usually the patient present with fever, jaundice, and right upper quadrant pain or the epigastric pain. So when it is with hypotension and the altered sensorium, they called as this. The symptoms are named as Raynaud's pentad. So the next thing, most important thing when we come to the common bile duct pathology is MRCS syndrome. So this MRCS syndrome is nothing but a stone in the infundibulum or in the Hartmann's pouch compresses the common bile duct to form a pathology or a fistula in the common bile duct. Sometimes it presents as elevated bilirubin, can mimic obstructive jaundice. Four, five types of Merz's syndrome. One is the external compression with impacting the neck of the gallbladder at the cystic duct, but it doesn't cause much of the compression of the much of the compression of the common bile duct. The second type, at least less than one third of the circumference of the common bile duct is less than one third of the common bile duct is involved, and uh, circumference of the common bile duct is involved, and in type 3 it's one third to two-third of the circumference, and in type 4 more than two-third of the circumference is involved. In type 5 it's cholecystoenteric fistula. So that means there is a communication between either the cystic duct with the common bile duct or the gallbladder with the duodenum, causing the stone to get dislodged into the intestine, causing the gallstone ileus. Okay, so what are these are the few indications for prophylactic cholecystectomy. I'll talk about the cholecystectomy and the um, uh, uh, pathology of the gallbladder in some other time. And these are the indications for prophylactic cholecystectomy, even if there is a stone or there are no stones. So the diabetic patients are more prone for biliary dyskinesia, and they get it done if there is a symptom or if there is some right upper quadrant pain. When there is a biliary dyskinesia, which can be picked up by the HIDA scan, and the patients going for bariatric procedure, especially the patients those who are um, planning for Roux-en-Y, they go for prophylactic cholecystectomy. Any patient those who have the blood disorders, Uh, those have blood disorders like hereditary spherocytosis or post-heart hereditary spherocytosis or thalassemia. They are more prone for they are, they can go for prophylactic cholecystectomy nowadays. The patients, those who had heart transplant, go for prophylactic cholecystectomy. Not sure what's the reason for cholecystectomy. The patient who has got a heart transplant. So next slide is the what are the investigations for the common bile duct stone, and the most common investigation which is done in UK to pick up a common bile duct stone is the ultrasound, which shows the common bile duct dilatation. And if it is, as I said you already, if the common bile duct is more than 8 mm diameter, or if it is more than 10 mm diameter in a post-cholecystectomy and with deranged LFT, we think about a common bile duct stones. And the next comes, if there is a common bile duct stone, the confirmatory will be either ERCP or MRCP. Sometimes the MRCP cannot pick up a microlithiasis, which can be picked up by the endo ultrasonogram. So the first picture shows the reconstructive image of the biliary tree in the MRCP, which shows the bile and the passage of bile So in MRCP, the bile acts as a uh, contrast to get the image, to get the MRCP done. And in ERCP, it is done under fluoroscopy. Here we could see two huge stones. This is the biliary tree with dilatation, and this is the endoscope. And there is a stent which is placed, or the dye which is which is pushed into the common bile duct, which shows the common biliary tree and anatomy, and the common bile duct with the filling defect in the common bile duct, which shows there is a common bile duct stones. And using ERCP, the stent can be passed in and it can be retrieved. And we'll discuss about these things in next few slides. So this is the sorry, I think there's some kind of interruption this today with plenty of disturbances. I don't know what's the reason. Uh, Okay, this is regarding a common bile duct stone, which is seen in EUS or endo ultrasound, where there is a microlithiasis which can be picked up easily in the endo ultrasound. So in UK, in NHS, the first investigation of choice is ultrasound with LFT, the liver function test, and if it is picked up, they go for MRCP, and if the MRCP shows the confirmatory diagnosis of gallstones, either ERCP, and if the patients are symptomatic still, and if the MRCP doesn't show any common bile duct stones, and there is an indication for endo ultrasonogram. Okay, so what is the treatment for any common bile duct stone is so we have to remove the gallbladder. That's first thing. And the second thing is taking off the stones from the common bile duct, either by surgical method or by endoscopic, or by ERCP. So nowadays the preferable in NHS, most of the surgeons, they prefer to go for most of the surgeons, they prefer to go for laparoscopic approach. They go for laparoscopic bile duct exploration, and either it can be transcystic through the cystic duct or through the common bile duct. and they use 3 choledocoscope to visualize the stones. And the duct is inflamed. The duct is inflamed and friable, and they put a T tube and come out. And I'll explain the procedure in detail in the next few slides. Coming on to the next slide is the okay. What are the approaches to abnormal LFTs prior to laparoscopic cholecystectomy, and how the surgeons predict there could be a gallbladder, a common bile duct stone? Always, we don't go for. It's not possible to get an intraoperative cholangiogram. So there are three criteria. They have classified the risks of common bile duct, the possibility of common bile duct stones into three types: high risk, intermediate risk, low risk, and minimal risk. So if your patient has got normal LFTs and a normal ultrasound with normal CBD diameter, so the risk of getting the relative risk of CBD stone is just 0.01. And if it is just single elevated alkaline phosphatase or AST or ALT, and with the history of acute gastropancreatitis, still there's a less chance of common bile duct stones with 0.15%. And when there is a high risk. So what are the most high risk causes? So any patient who has got jaundice and deranged LFT with preoperative ultrasound showing dilated common bile duct, or if the MRCP show dilated common bile duct, then there's a high risk of them having common bile duct stones. And what is intermediate pathology? So this category needs MRCP. So this category of people are trialed now under Sunflower trial in many of the hospitals, NHS trusts. There are recruitments going on to know whether these patients in this intermediate group needs MRCP or not. So the criteria are the bilirubin. When the bilirubin is greater than 20 millimoles, and there is a 2 to 3 times increase of alkaline phosphatase or AST or ALT, and when there is a dilatation of the common bile duct in the ultrasound. So when these three things are there, there's an intermediate risk of um, common bile duct stones. So those patients may need MRCP to make sure that they don't have stones in the common bile duct. So what exactly is the confusion or the controversies here in common bile duct stones? So most of the people they do a there's an most of the people they um, go with a common bile duct. When there's an asymptomatic common bile duct stone, they prefer to get a laparoscopic or open bile duct exploration. When they come back for surgery, 25% of the patients, those who were discharged with common bile duct stones with normal LFTs, everything, and we find some common bile duct stone. 25% of people, those who come back for laparoscopic open common bile duct exploration, they pass the stone, and when we do the procedure they may not be having a stone in the common bile duct. So unnecessarily we are subjecting the patient for common bile duct exploration. So what are three approaches usually we do to avoid this? Most of the patients they get ultrasound, and when the CBD is dilated they go for EMRCP. When it is confirmatory they go for ERCP, and avoid intraoperative cholangiogram. Again, intraoperative cholangiogram is a tedious procedure, asking the radiologist to be available or the radiographers to be available, putting on apron, lead apron, and making sure that the imaging happens in a theater setup. It's a tedious process, and it involves plenty of things around it. So to avoid so uh, to have a clear approach for common bile duct stones treatment process, plenty of people go for the first approach, and the second approach is intraoperative cholangiogram for all cases. And it's not that easy for NHS to get IOC for all patients, and because it is because of the cost effectiveness and the human resources. So intraoperative cholangiogram for all cases, and if the patient is found to have CBD stones during the um during the IOC, they go for perioperative, intraoperative CBD exploration at the same time, or sometimes post-operative ERCP if the surgeon is not confident enough to do a CBD exploration. And the third approach to avoid this thing is no investigation, just do a lab chole, come out and clinically check the symptoms. The patient is asymptomatic and the LFTs are fine. If the patient is recovering, just leave it. And if the patient has any signs of obstructive jaundice, go for ERCPR, whatever ERCPR. Uh, uh, it's better to do a ARCP, and they cannot be pushed into the uh, surgical approach. And there are small proportion of patients undergoing lap chole, regardless of pre or intraoperative investigations, will thus have missed CBD stones. So the first sentence, the first line, and the second line is the controversy. So though the patient goes home and comes back with CBD stones, when we do the surgery, there's a chance of 25%. There's a chance of past stones, and those patients, those who have lap chole and go home, and they can be coming back with a missed CBD stones with all these things happening. So these are the controversies which are keeping in dilemma to go for which option is more appropriate for any CBD stones. And this is again another flow chart how to go about with any gallstones. So as I said you already, normal LFT, normal ultrasound, and it's minimal risk of there's a minimal risk of CBD stones. The patient goes for laparoscopic cholecystectomy. It depends upon the on-table cholangiogram if needed, plus or minus. But however, when the patient has got intermediate risk, like any one of the values deranged, either LFT or the ultrasound, or dilated duct, bile ducts. There's an intermediate risk. The patient goes for lap chole with on-table cholangiogram, and the patient gets the CBD stones extracted either by open or uh, lap CBD exploration, intraoperative ERCP. Again, this one is even considered nowadays in NHS for easy treatment approach and decreasing the time duration. And there is other approach called as anti-gate CBD stent, secure the cystic duct during the procedure and do a post-operative ERCP. Even that one is again appreciable. And the last one is any patient, those who have highest risk of CBD, definitely they have to go for MRCP, get the CBD stone. If the CBD stones are there, then they go for pre-operative ERCP, then plan for laparoscopic cholecystectomy with plus or minus on-table cholangiogram. There is no CBD stones, and even if there is a patient with no CBD stones after MRCP with clinical symptoms, these patients are subjected for endoscopic ultrasonogram, and then they go for laparoscopic cholecystectomy. So the use of T-tube is again another controversy here in this era of laparoscopic procedure. T-tube usage is no more followed that commonly. The T-tube usage is highly, they don't go for T-tube usage, and they go for primary suturing of the common bile duct. And the presently the UK guidelines says that they are training the fresh surgeons for laparoscopic common bile duct exploration rather than open procedure. And most of the surgeons in UK, 86% of the surgeons in UK would choose preoperative ERCP over common bile duct exploration. So that decreases the risk of common bile duct exploration, like stricture, common bile duct stricture, or leaks post-operatively. So with this, in this era of laparoscopic cholecystectomy, there's an increased chances of bile duct injury. So the major disadvantage of this widespread introduction of laparoscopic cholecystectomy has become the rising incidence of bile duct injury. And in UK, there are 96% laparoscopic cholecystectomy compared to the open cholecystectomy. And when we are going to say bile duct injury, at least 25% of the circumference of the common bile duct has to be injured to say that it is a bile duct injury. And the most important thing is intraoperative bile duct imaging and prevention. Bile duct imaging prevents the bile duct injury. Selective cholangiogram appears to be favored approach, with the intraoperative cholangiogram performed in less than 10% of the laparoscopic cholecystectomy. So, as I said earlier, IOC is a bit tedious and cost. It's not a cost-effective approach for avoiding common bile duct injury. So, what are the methods how we are going to avoid common bile duct injury? There are three things which can be done. One, the first and foremost important thing is uh, dissecting the Kellett's triangle, the Kellett's triad, and attaining the critical view of safety. So when we say the critical view of safety, it's nothing but the two structures which is parallel to each other. One is the cystic duct, and the second is the cystic artery, which has to come out of the gallbladder, or which has to be, which are the two structures which should be attached to the gallbladder. So when these things are there, then the critical view of safety is attained. And this the Kellett's triangle is nothing but formed by the common hepatic duct medially on the left, and inferiorly the cystic duct, and superiorly the uh, lower surface of the liver, and it contains the cystic artery. The next thing is the ruveus sulcus. When we do a laparoscopic cholecystectomy, the ruveus sulcus is the landmark, which is the sulcus which is found on the right side of the right lobe of the liver, which that is a landmark where the dissection has to happen superior to the ruveus sulcus and not inferior to the ruveus sulcus. When the when we go inferior to the ruveus sulcus, there is a chance of injury to the major blood vessels, especially the hepatic artery, and uh, uh, this can cause a vessel injury rather than a common bile duct injury. But still, it's very important to know that. And next is the what are the common other thing which I wanted to mention is the flag sign, which is no more used. Flag sign is nothing but we flag the gallbladder after dissecting the callots. It usually freely moves. That's called as flag sign. And next comes the what are the risk factors for bile duct injuries. And it's commonly accepted that the dangerous surgeons or the dangerous surgery is the most common cause of bile duct injury, and the dangerous thing in the anatomy is just 7%, and the dangerous thing by the surgeon is 84%, and chances of dangerous pathology is just 9%. So most of the bile duct injuries are because of the surgeons, not because of the anatomy. However, there are few chances because of the dangerous pathology. So what are how we classify the bile duct injury, and this is given by the Strasbourg classification, and there are five types: A, B, C, D, and E, and he has got another five types from E1, E2, E3, E4, and E5. And this is very important, and this is very easy to remember. Any cystic duct clips which is left and which can be which is slipped becomes the A, or the cystic duct starts pouring out the bile, which is A, which can be dealt easily by an ERCP when the sphincter spasm is released, when there is a continuous flow of bile into the common bile duct. This thing can be settling down, but however, the patient needs a drain to be put in to avoid the spillage of bile into the peritoneum and causing the irritation of the diaphragm and causing the sepsis. And the type B, again, there is a two clips on both the sides, which is very close. The clip the injury is very close to the common bile duct, and very close to the common bile duct. Again, this injury can be again treated by ERCP. So in all the patients, they need they need a drain either in the both in the subhepatic region and also in the Morrison's pouch to avoid spillage. So in the third type, there is the stump is sure about the thing. The injury to the the injury to cystic duct has happened, and there could the duct is this is the accessory duct which could be causing a damage to the which could be causing a damage to the common bile duct, and the bile drains in the third type. And the fourth type, the cystic duct is clipped, but there is a damage to the main common bile duct with at least 25% involvement. And the fifth type is the most important type, which is which causes plenty of problems. And the common bile duct injury to the common bile duct is 2 centimeter distal to the confluence of the common hepatic duct, and if it is less than 2 centimeter in the distance between the confluence of the common common confluence of the hepatic common hepatic but both the left, right, and left hepatic duct, then it is type E2. And when the stricture is at the level of the common confluence of the hepatic ducts, it is E3. And E4 is it extends into the left or right hepatic duct. And E5, which involves all, and it extends more into the um, which extends more into the liver substances. Okay, and this is nothing but a stricture which is formed due to the common bile duct injury. Again, it's the same like that of the E type of the Strasbourg classification. When the stricture of the, it's called as Bismuth classification of biliary stricture, which, when the stricture is greater than 2 centimeter from the common confluence of the confluence of the hepatic ducts, then it is type 1. Again, it is less than 2 centimeter, it is type 2. If it is at the level of the confluence, it is type 3. And if it is into the right side, if it is type 3A. If the stricture is into the left hepatic duct, it is 3B. And 4 is above the destruction or the substance loss of the structure happens above the hepatic duct confluence, then it is type 4. Involvement of all the sectoral or any other thing which enters into the liver is type 5. It's type 5 Bismuth classification of biliary strictures or the biliary injury. So how are we going to manage any bile duct injury? The most important thing in management of the bile duct injury is intraoperative assessment. If the patient, if the assessment happens, if the surgeon is surgeon uh, understands that there is a common bile duct injury, the repair is very easy. Per-operatively, try to manage the patient intraoperatively. For example, there is a type A injury, do a clip, again do a ARCP post-operatively. If it is a type B and C and one to E1 to E5, primary suture with a drain is easily possible. And if there is a complete injury with a loss of substance, go for a hepaticojejunostomy, and that's better. If it is just mild without a loss of substance, it's just primary suturing. If there is a loss of substance like uh, if there is a part of the common bile duct which has been removed, it's better to go for a hepaticojejunostomy. When there is a thermal injury, extensive thermal injury, and when the surgeon is not sure of suturing the bile duct, which can lead on to the still more leakage, or there is a damage to the common bile duct, then again go for intraoperative biliodigestive anastomosis or hepaticojejunostomy. And if the surgeon are inexperienced in the common bile duct exploration or in dealing with the common bile duct, better to refer the patient to a tertiary center. And what happens if it is not possible to assess during intraoperative period? So the patient goes for post-operative period, and the patient starts pouring bile into the drain, or there is an abdominal distension which causes obstructive jaundice like picture, then um, then do an MRCP and assess the whether the and assess do an ERCP and assess what type of injury has happened, and accordingly the patient managed. Usually, it's called as early bile duct injury repair or the late bile duct injury repair. If it is less than 8 days, still it is possible to repair, and if it is late, more than 6 weeks, it's better to go for a ERCP in the meanwhile and try to repair it after 6 weeks when the uh, things when the inflammation settles down. And there is something called as and most common surgery which is done for bile duct injuries, hepaticojejunostomy, and post-operative MRCP and ERCP, as many as 32% will require hepaticojejunostomy. So, what is the timing of repair for any patient those who have bile duct injury? Is usually early repair, intraoperative. It's definitely more easy, and primary suturing is possible. And again, still the earliest is 48 hours, and the late repair is nothing but 8 days to 6 weeks, depending upon the patient. When there is an associated vascular repair, it still more complicates the situation. So there can be a chances of hepatic necrosis, and there's a chances of liver resection as well, and there is a injury to the major blood vessel in the liver hilum. That's why I said about the hepatic liver hilum in the first few slides. And management of complications related to. Sorry, again, there's a problem. Okay, so coming on to the timing of repair, and as I said, you early repair, intraoperative repair is very important. Early repair is advisable always. Intraoperatively, the patient can be managed immediately. It's the best choice. And if the patient cannot be managed intraoperatively, and if the surgeon is not aware that that biliary the common bile duct injury has happened, better to do it as early as possible before 48 hours, and the delayed repair can happen in 8 days to 6 weeks, which has got still more plenty of. So as I said you about the management of, someone is drawing the things which are on the screen. Please no, it interferes with the presentation. Uh, Again, the management of complications related to repair. So any patient who have common bile duct injury and which who are managed intraoperatively or post-operatively, they are more prone for enteric stricture. So that's again a difficult thing to be managed. So they need a dilatation of the things or the PTC, which needs to be done. And the revisional surgery, again, it goes for hepaticojejunostomy always. And when the patients are not able to be treated with the revisional surgery, or when the revision surgery again goes for failure, there's a role for liver resection or liver transplantation. Um, uh, so this is a study where they identified 5.6% of the patients in their study who required a hepatectomy after a uh, bile, common bile duct injury and the revision surgery. So post-operative biliary fistula. Um, this is again the most important thing which I want to stress is here. So any patient, those who have bile leak, is considered as biliary fistula, and the most common causes of bile leak after any laparoscopic cholecystectomy is from the cystic duct because of the slippage of the duct. And the second common cause is the duct of Luschka, which is injured during the surgery, and there can be a bile leak from the liver bed, which settles usually with the drain, and there is no need to worry about it. Just keep the drain in, and try to monitor the drain. Conservative management of the patient settles down and the patient goes home. And the treatment of the biliary fistula is usually ERCP, which is very, very important. Any patient who has got bile in the drain, try to do a sphincterotomy. This releases the common bile duct pressure, and there is a continuous flow of bile into the duodenum, thereby decreases the pressure in the cystic duct and the clip. And for complete transaction, if there is a transaction of, if the surgeon thinks that um, there's a transaction of common bile duct, then try to do a ERCP and MRCP, ERCP and the MRCP, and then following which they need an ERCP. And the most important thing which I want to stress here is try to avoid CT-IVC. It's not indicated, as the contrast bilirubin will not be excreted during the, because of this CT. And okay, so to stress a few things about what the guidelines says in NHS, for the NICE guidelines says to practice in NHS is, uh, so any patient, those who have gallstones, try to do a LFT, as I said you already, and ultrasound. And as I said you before, if the ultrasound or the LFT is deranged, do as such. Like if anyone is deranged, there's a high chances of um, CBD stones, and go for a MRCP. And this is under trial for sunflower trial. And if there is if the MRCP is not picking up any stone, and still if the patient has got symptoms of common bile duct, then go for endoscopic endoscopic ultrasound. And comes the next slide is, okay. So what is this is if this is the guideline, if the patient has got GB empyema. So if the patient has got confirmed gallbladder empyema, try to do a laparoscopic cholecystectomy or open cholecystectomy if the patient is fit enough. If the patient is not surgically fit, try to go for a cholecystostomy or conservative management. And what is the nice guidelines regarding the common bile duct stone? And offer bile duct clearance always with a laparoscopic cholecystectomy to people with symptomatic or asymptomatic common bile duct stones. Though there are few patients, those who can pass stones without having common bile duct stones. When there is a common bile duct stone, the NICE guideline says to, though they are asymptomatic, we have to offer them a bile duct clearance and the laparoscopic cholecystectomy. And when there is, so how the patient is going to get the bile duct cleared? Uh, uh, Always laparoscopic cholecystectomy should be done for these patients, and it depends on the surgeon whether to do a ERCP perioperatively, preoperatively, preoperatively or perioperatively, and it doesn't advise about the postoperative ERCP until otherwise it is missed or something. And next slide is, so what is the advantage of MRCP versus endoscopic ultrasound in terms of gallstones? MRCP is always accurate compared to EUS. It's both are almost equally has got sensitivity, and EUS takes the slight slight edge over the MRCP. And there's no strong evidence to say that EUS is superior to MRCP in terms of common bile duct stones. And uh, but still the EUS is considered as best investigation to pick up the microlithiasis. Advantage of MRCP is non-invasive and it carries negligible risk to the patient. And ultrasound, endoscopic ultrasound has most accurate for microlithiasis, and it has got some high side effects and lethal side effects, including chances of death. That's mentioned in the literature. Uh, regarding the laparoscopic cholecystectomy after CBD stones. So, what's the guideline says about the laparoscopic cholecystectomy after CBD stones? The patient is diagnosed with CBD stones. The patient goes for ERCP. So, all the patients, those who have CBD stones, must be offered laparoscopic cholecystectomy. Either it could be early, so within 2 weeks of bile duct clearance, or it can be delayed until 6 weeks after bile duct clearance. And there is lack of evidence again, which shows which has got the best approach. Either it is early or late. There's no evidence, so it can be done at any time at this moment. Either early laparoscopic cholecystectomy or late laparoscopic cholecystectomy after CBD exploration. And a bit about laparoscopic CBD exploration, the port placement, the position of the patient, anesthesia, everything are same for the laparoscopic CBD exploration with the lap cholecystectomy. There are two approaches again, as I said, you transcystic approach and choledochal approach, or direct opening of the common bile duct. The indication for transcystic approach is the common bile duct should be less than 7 mm, and there should not be more than 6 to 8 stones, and the stone should be less than 1 centimeter or 10 mm. And the cystic duct diameter should be greater than 4 mm, and that can be dilated to 6 mm with the Fogarty catheter. And the stone location should be either distal to the uh, uh, cystic duct, or uh, in the junction between the cystic duct and the common bile duct. And the lateral entrance of the cystic duct to the it should be the stone should not be exactly opposite to the lateral entrance of the cystic duct. So the most important step in CBD exploration is flushing of the bile duct. Try to flush the bile duct as much as possible to remove the microlithiasis and clearance of the non-obstructing CBD stones. Don't flush the proximal part because the stone can dislodge into the hepatic duct and can form again a sepsis, or it cannot be removed again. It can form a nidus there. And the flushing is always done by warm saline. And I'm not sure why the warm saline is used. That can be they use intraoperative glucagon to relax the sphincter of Oddi during the flushing time, during the flushing of the common bile duct. And the cystic duct can be dilated up to 6 mm using a Fogarty catheter. So what is the choledochotomy approach? Again, when the patient, when these are the indication uh, where the choledochotomy approach is done when there is a contraindication for transcystic approach. And the where exactly we place the incision is 2 centimeter above the duodenum. At least 1 centimeter is created. 1 centimeter of incision is uh, done over the common bile duct. Try to avoid plenty of dissection over the common bile duct. It devascularizes the tissue as early, and try to avoid diatemy as much as possible. Use a laparoscopic blade or a laparoscopic scissors to open the common bile duct. Put in a tube and put in a tube and usually a 12 French tube, which can helpful, and flush the thing. Try to bring out the stones using a Damier basket, or try to squeeze it out. And uh, again, the usage of T-tube, 12 French or 16 French, is again a controversy. Primary suturing is always done. Nothing wrong in placing a T-tube if you think that there is a residual stone is suspected. And the ERCP can be done, or a T-tube cholangiogram can be done after a CBD exploration to make sure that the common bile duct is clear without any stones. And before removal of T-tube, better to do a T-tube cholangiogram to check is there any residual stone before we take out the T-tube, and the T-tube can be removed in 2 weeks time. Thank you all for listening. I think there was a plenty of disturbances this time during this, and I'm opening up the Um, Anyone who wants to ask the question, they can do it. Sorry, there was some interruption be here and there during this thing. Anyone who wants to ask, discuss, they can raise the question, or open up the, they can unmute themselves and talk now. I think everyone can unmute. Probably it was mute for a long time because I made it mute from my end, and you can open up from your side. Time for discussion, guys. You can unmute and ask questions if anyone wants any clarification or anything to be discussed. Ready to help you guys, and ready for the discussion now for another 5 minutes. Sorry for the interruption. I think there was a person who messed up the whole of the picture in the middle of the presentation. So no questions. If there is any question, they can come up. If not, can wind off. Okay, thank you all for coming and attending during the weekend. I think going to stop sharing all these things, and